So, good evening, friends, and welcome to this episode of our Webflix series. As you all know, it's cricket season, and we have named it the third umpire. And when it comes to antibiotics and infectious disease, all of you will agree that our faculty for today, Dr. Tanu Singhal, is definitely the third umpire whom nobody can dispute, and everybody has to accept her verdict. So I think let's have some good revision of learning of antibiotics in office practice. As you all know, these sessions are not, they're designed differently. So there's no PPT, there's no lecture. There are only practical questions useful in day-to-day practice. And our moderator for today is Dr. Ripa Agarwal, our EB member. So she'll kickstart the process with a few questions, and then audience can definitely pitch in at any time as a tangent to that question or any other question, and those questions will be picked up and answered. So I think let's start learning. Over to Dr. Ripa and Dr. Tanu Singhal.
Thank you so much, sir. And thank you, Tanu ma'am, for sparing your valuable time. So I'll just start with the questions. So, madam, as we know, it's a very common scenario that we get a child with some fever and cough, and then the child is also complaining of some ear pain. And ma'am, most of the times, like an otoscopy is not done. So, ma'am, in such situations, like, do we label it as acute otitis media, and then do we treat it accordingly? Ma'am, what do you think?
No, I think we really have to invest in diagnostics. So, an otoscopy is really important. And even earlier, I used to be very hesitant doing it. But if you do it, and I confess, I don't have a pneumatic otoscope. I have the normal otoscope, but definitely I make an attempt to look into the ear. And sometimes I'm not successful because there's wax or something, but that's a different matter. But let us say that you have seen some congestion of the tympanic membrane and you have ear pain and all. Not every patient with acute otitis media needs antibiotics. So if the child is above the age of 2 years, if the disease is unilateral, and if the patient's fever is not very high and there is no pus discharge, you can actually give symptomatic therapy with either paracetamol or ibuprofen and watch the child over the next 48 hours before starting antibiotics. So I think it's important that even if you're in doubt about the diagnosis of otitis media, it is better to just give symptomatic therapy and call the patient after 48 hours for a re-evaluation rather than giving antibiotics upfront. You are mute. Can't hear you.
Can you hear me now?
Faintly.
So, ma'am, just adding to it, am I audible?
Yes, yes.
Yeah, better.
So, ma'am, suppose now the pediatrician has called the patient after 48 hours and an otoscopy also was performed, and now it's confirmed that it is acute otitis media. So, ma'am, which antibiotics do you recommend, and for ma'am, what duration?
So I would recommend amoxicillin as the first drug of choice because most of our pathogens are pneumococcus, Hib, Moraxella. It may be virus also. So amoxicillin in a standard dose of 40 mg per kg per day is recommended. However, there are some patients, like for example, who have had infection in the past 30 days, has received amoxicillin earlier, or if the patient has purulent conjunctivitis indicating that Hib may be a pathogen, or if the patient is having has received these then, or is having very severe disease, really high fever and really toxic child, then co-amoxiclav should be used. And the duration of therapy is, if the child is below the age of 2 years, then you use 10 days treatment. And above the age of 2 years, you give 5 to 7 days of therapy.
And ma'am, like duration now we have understood. Ma'am, what about the dose? You said for amoxicillin like 40 mkd, but ma'am, what about 90 mkd? Do you use that as well?
Yes, so there are some cases, where you would use a higher dose of amoxicillin. I would not recommend it upfront. But yes, suppose you have treated a patient with standard dose amoxiclav and the patient comes back, either there is treatment failure or the patient comes back with a recurrence. These are the kind of patients where you can use a higher dose because there's a possibility that drug-resistant pneumococcus may be there, or even for Hib, a higher dose may work better. So we should restrict the use of the higher dose for patients with either treatment failures with the standard dose or with recurrent otitis media.
So, ma'am, point well taken. So, we'll be restricting the dose to 40 mkd only unless there is a treatment failure or is it something severe. Okay, ma'am.
So, yeah, you can say it is like 3 lines. First is amoxicillin. The second line is amoxiclav standard dose. So, first is standard dose amoxicillin, then standard dose amoxiclav, and then high dose amoxiclav and or ceftriaxone. So, I have actually seen, in some patients where earlier you had to kind of hospitalize them for ceftriaxone because of, severe pain and all, using a higher dose is almost does the same for these patients.
Okay. And ma'am, there is a question by the audience, or the audience have started participating, ma'am. So if there's a Dr. Prabha is asking 35 days baby with ASOM. So what would be the antibiotic of choice? So it's an
so here, yeah, I would probably use co-amoxiclav here because, it's like a small baby and there is, the chances of complications like meningitis, mastoiditis, etc. are high. So maybe in this situation, I would go ahead with co-amoxiclav standard dose.
Standard dose only, ma'am.
Yes, yes.
And ma'am, one more question by Dr. Sanghvi is, if patient has received full course of Hib vaccination, so does that rule out Hib infection altogether? As you said, like one of the organisms could be Hib.
No, definitely not, because the Hib vaccination is against typable Hib B, Haemophilus influenzae type B, and you have other Haemophilus or you have non-typable Hib, which also cause otitis media. So neither does prior history of pneumococcal vaccination nor history of Hib vaccination precludes these pathogens. And we also know for pneumococcal vaccination, the protection afforded against otitis media is just 7 to 10%. So this is basically non-invasive disease, mucosal disease. So we can't exclude that. So, we cannot say that if this child has received Hib vaccine, which most children you can use amoxicillin because Hib would not likely be there. Because again, Morixella can also be there, non-typable Hib can also be there.
And ma'am, similarly, there is one more question that in recurrent otitis media, wouldn't a different antibiotic be preferred over increasing amoxicillin if it is a recurrent case?
Okay, so when you have recurrent otitis media, one is you have to also look at why the child is having it. So it may not just be a choice of antibiotics, but if the child has adenoid hypertrophy, allergic rhinitis, GERD, those issues have to be addressed to prevent recurrence. But, because people are asking why use high-dose amoxiclav, why not use cefpodoxime, why not use cefuroxime? Because studies have shown that the level achieved in the middle ear fluid, which is also like a sanctuary site, is best with amoxicillin. And higher dose amoxicillin helps you. So for treatment of DRSP or intermediately resistant pneumococcus, high dose amoxicillin is definitely superior to cefpodoxime or cefuroxime. So also here I would like to mention that some drugs should not be used for acute otitis media like azithromycin, because there's huge resistance to azithromycin. Unless of course you have a severe beta-lactam allergy, then you try it. But otherwise don't use Azi for acute otitis media. Stick to amoxicillin or amoxiclav.
Sure. And ma'am, similarly, like ma'am, as you mentioned that if there is recurrent otitis media, we have to look for the causes. Ma'am, now suppose a child has adenoid hypertrophy. And in this situation, now instead of like giving amoxicillin every time, ma'am, do you still prefer giving amoxicillin or would you then go for cephalosporins?
No, I would still stick to amoxicillin, because if you look at the guidelines, if you look at the AAP guidelines, if you look at the IAP guidelines, you look at up to date, they all talk about amoxicillin as the drug of choice, and you use cephalosporins only if you have, non-severe allergy to penicillins. Then you could use cephalosporins like maybe cefuroxime. Sometimes, you have a situation where your patient gets severe diarrhea with amoxiclav. Okay, so there you may try and use a cephalosporin because, cefuroxime, etc., the diarrhea incidence is less. So I would reserve the use of cephalosporins for those situations.
Okay. And ma'am, as you mentioned that with amoxicillin, we can get diarrhea. So ma'am, do you prefer giving prebiotic or probiotics to your patients when you're prescribing amoxiclav or amoxicillin?
Not proactively. So definitely not proactively, because you can so only if they get diarrhea, then you can actually use a probiotic. And another option is that if you use the new amoxicillin extra strength, amoxiclav ES, there the ratio of clavulanic acid to amoxicillin is 14:1, unlike the 7:1 ratio. So the incidence of diarrhea may be lower there. So that is also something which you can use in this situation.
Okay, ma'am. And ma'am, like we have discussed about the conservative management. Ma'am, when do you like opt for a surgical management in cases of recurrent otitis media?
I, usually send it to the surgeon, but basically, if you have a persistent middle ear effusion,
Please kindly mute Dr. Khan.
Okay. So, for example, if the patient is, having a persistent otitis media with effusion, even after 2 to 3 months, that would be the instance where you would send them for tympanostomy tube placement. If you find their hearing deficit, if there's finding persistent middle ear infusion on the tympanometry, or if your patient is having massively enlarged adenoids with OSA or recurrent sinusitis, then you would send these patients for adenoidectomy. But I use the intranasal steroid spray, and in many cases, that alone takes care of this upper airway obstruction. So that helps in these patients.
Okay, ma'am. And ma'am, now moving from the middle ear to the external ear, ma'am, can you highlight treatment for otitis externa?
So otitis externa is generally because of Staph aureus most of the time. So generally of cefalexin is a good antibiotic for these patients. I prefer cefalexin to coamoxiclav in this situation, because cefalexin is more narrow spectrum. Coamoxiclav works on your anaerobes, it works, etc. So it destroys your gut flora. So I would, wherever I'm thinking of Staph aureus as a possible culprit, I would prefer the use of first generation cephalosporins like cefalexin or cefadroxil. And that applies to even pyoderma.
Okay. And ma'am, in upper respiratory only, ma'am, now suppose if you have a child of acute sinusitis, so ma'am, then which is your preferred antibiotic?
So again, it's exactly like otitis media. If you have mild sinusitis, child not toxic, you can use amoxicillin standard dose. But if you have a child who has who's quite having high fever, who's received amoxicillin before, then I would use coamoxiclav both in standard doses. And one important thing about management of sinusitis is that you should treat for 10 to 14 days. So it's paradox that you can get away by treating pneumonia for 5 days, but for sinusitis, you need longer treatment because otherwise these patients relapse. So 10 to 14 days therapy is important if you're suspecting bacterial sinusitis. So that is why it is very important for you to be sure about whether antibiotics are indicated or not, because either you don't give your antibiotics to a URTI, or if you're giving antibiotics, then use the proper dose and use the proper duration. And that is why I tell many of my patients who keep, harassing me, give antibiotic. So I say that, look, if your child is stable, we can always wait. There's no hurry, because once I start an antibiotic, I'm going to ask you to give for 10 to 14 days. Are you ready for that? And most of them think that once an antibiotic is started, 3 to 5 days is enough. So that is why you have to be really sure that an antibiotic is indicated, because once you start and the patient gets better, then you're committed to giving 10 to 14 days of therapy.
Sure, ma'am. And ma'am, as you mentioned that if we are, giving the antibiotic when it was not indicated, mostly in the first week of illness. So then in the second week, we really don't know what has to be done, ma'am. So ma'am, sometimes we see that the patient has received azithromycin. And then in the second week, by that time, the patient is now developing sinusitis. So ma'am, what is your advice in such patients?
So that actually illustrates a very important point, that antibiotics do not prevent bacterial superinfection. Okay, so now if you are sure that you're dealing with a bacterial upper respiratory infection, then you would have to go down the path of either amoxicillin or coamoxiclav. So even if this patient would have received coamoxiclav in the first week as an antibiotic, you could still go ahead and use that, because as you know that they wouldn't prevent a superinfection from happening.
Sure, ma'am. And ma'am, on the same lines, there's a question like, what are the clinical clues to suspect sinusitis in kids with respiratory symptoms?
So usually there are three types of presentation. So one is, you have a patient who had fever, cough, cold, like a viral URTI, got better, and then who's having, then again starts getting symptoms 3 to 4 days later with fever and, thick nasal discharge, headache, then you would suspect sinusitis. The second thing is that your patient who should get better in 3 to 4 days time, after a viral URTI doesn't get better and continues to have high fever, headache on 5th day. This third possibility is that your patient continues to have a thick nasal discharge 10 to 14 days after a viral URTI. So these are the three situations where you would suspect sinusitis.
Sure. And ma'am, is there any role of N-acetylcysteine or vasoconstrictors like phenylephrine for sinusitis?
So N-acetylcysteine definitely not in management. And most of these patients actually need nasal decongestion with saline nasal spray. That is best. And also you can use a intranasal steroid, especially if you're suspecting that adenoids are behind it. I mean, nowadays we're seeing so many children with recurrent sinusitis because of allergic rhinitis and adenoid hypertrophy, that you can give that intranasal steroid spray also in the setting of an acute infection, because that helps in, clearing up the sinuses faster.
And ma'am, then you prescribe that steroids for a longer duration, right? Even if when the infection has subsided.
Yes. Yes, and you would tell these parents that give it for a month and then stop it. And the next time, the moment the child starts having a runny nose or allergy, you should start the spray immediately rather than wait for 7 to 10 days. Because if that allergic rhinitis goes on, long, then it will get converted to a sinusitis.
Yes, ma'am. Ma'am, similarly, ma'am, as we're discussing about nasal sprays, ma'am, Dr. Sanghvi is asking, ma'am, what about fluticasone with oxymetazoline?
I don't know if such a combination is available. I really don't know. I would not use it because you know that if it's oxymetazoline, you can't give it for more than 3 days. Otherwise, there will be tachyphylaxis, and the fluticasone you would have to give for a longer time. Maximally, what I sometimes do is, if the congestion is bad, is maybe just give them a single medicated nasal spray at bedtime. Okay, for 2 to 3 days, because so that the child gets relief for a lasting time, and during the day you use the normal saline spray. Maximally, you could use that in that fashion, but you have to be very careful. Tell people that, you can get rebound nasal congestion, and this is something which should not be used in children below the age of 1 year, the medicated nasal spray.
What about local antibiotic drops?
Absolutely no role. I think the only role of local antibiotic drops is in chronic suppurative otitis media, CSOM, where you could use, Ciplox or gentamicin ear drops, but not otherwise. There is no role of topical antibiotics in acute suppurative otitis media. There is no role of using topical analgesics, like otogesic, etc., in patients with acute suppurative otitis media, because if you have to bring about pain control, then you have to use a systemic drug like either paracetamol or ibuprofen.
Ma'am, one more question was on otitis externa. Any role of topical antibiotics for otitis externa? You did mention about cephalexin or cefuroxime, but any role of topical antibiotics?
I mean, the ENT people do give it, but I generally stick to this. Sometimes, the pain is so intense of otitis externa that the ENT people do some packing which helps these patients. So they put some kind of medicated pack. So that I think one could do. But personally, I don't see that many cases of otitis externa. Most of the time, what you find is that the patient has a furuncle in the external auditory canal, and that causes extreme pain. So that is the time when you would give systemic antibiotics, ibuprofen, and sometimes packing helps.
Ma'am, we will now move to the lower respiratory tract, madam. So, ma'am, like for pneumonia, you mentioned that, we have to give antibiotics for 5 days. So, ma'am, now once we have given that 5-day antibiotic course, do we need to do a chest X-ray?
No, never. You never do a chest X-ray so quickly after treatment, because radiologic changes take time to get better. In fact, the earlier recommendation of doing a chest X-ray after 4 to 6 weeks in every patient is also doesn't really apply always, because why expose the child to radiation? So sometimes for example, if I've had a patient who had a pneumonia with empyema, I would do a chest X-ray at 6 weeks just to make sure that the lung is expanded. But if it was a simple consolidation and the child's clinical examination at the end of 6 weeks is normal, and this is a child who didn't have recurrent pneumonia, I would skip the X-ray. However, if there is a child who has recurrent pneumonias, then I would do a chest X-ray after 4 to 6 weeks to make sure that I can distinguish a residual abnormality from a recurrence. Then I would definitely do a chest X-ray. So chest X-ray at 4 to 6 weeks in children with recurrent pneumonias or who continue to have abnormal clinical examination or who had an empyema to begin with.
Sure, ma'am. Nowadays, we also see a lot of pertussoid like cough, ma'am. So there's a question on that, like how to differentiate between pertussoid cough to start with, which was dry, now has become wet, and protracted bacterial bronchitis.
See, we are like confusing like pertussoid cough. I mean, there's a specific case definition. So a cough which lasts, which is spasmodic or which is associated with post-tussive paroxysmal cough, post-tussive vomiting. So that is a different entity. And when we are talking about persistent bacterial bronchitis, we are talking about a cough which is wet. So pertussoid cough is typically a dry cough. Whereas here we are talking about a wet cough. When the child coughs, wo khad khad ka awaaz aata hai, you feel that there is phlegm in the chest. So if that is, so that I think is the main difference. Because if you have a patient who has persistent cough going on for a long time, which is sounding wet, then you have to suspect persistent bacterial bronchitis and start these patients on co-amoxiclav at 40 mg per kg per day and reassess them after 3 to 4 days. And if they are getting better, then you give them the full treatment for 2 weeks. However, if you have started antibiotics and the patient is not better after 3 to 4 days, then I don't think it makes real sense to continue to give for 2 weeks. Then you have to look at other causes. But that is how I would approach a child who has this kind of wet sounding cough where I'm suspecting PBB.
Sure. And ma'am, there is another question on what is the clear indication of azithromycin, because it's the most commonly misused drug.
So I would say in bloody diarrhea, you can use azithromycin instead of cefixime. The second is in typhoid or paratyphoid fever. It's a good option, alternate option to cefixime. Third is if you are suspecting an atypical pneumonia. So you have an older child coming in with a pneumonia where you're thinking of an atypical cause, then you use azithromycin. But azithromycin has absolutely no role to play in pharyngitis, streptococcal pharyngitis, acute otitis media, or sinusitis, unless there is severe penicillin allergy. And many times, people say that we used azithromycin and the patient got better. The reason is that the patient didn't need antibiotics in the first place. But if you were dealing with a true bacterial URTI, azithromycin would fail. And it's not us doctors only who are prescribing azithromycin. My patients come and tell me that, doctor, we were having fever and we started AZ and today's the third day, but the fever is not better. So a lot of patients themselves use AZ because for them it's like once a day therapy for 3 days. So that's really unfortunate. So another pointer is that whenever I meet a patient with a respiratory tract infection, I treat the patient and I always tell them for future infections what they should do. I always tell them that when your child gets fever, cough for the next time, please do not start antibiotics. Please give paracetamol, symptomatic therapy. And on day 4, if your child is not getting better or is having breathlessness, then seek medical care and then think about antibiotics. So you have to use that opportunity when a patient comes to you to educate for future times so that they don't do this same mistake again. Or if somebody prescribes them antibiotics, they're reluctant to take it.
Sure, ma'am. And ma'am, for this atypical pneumonia, as you mentioned about azithromycin, ma'am, there's a question about the diagnosis. So ma'am, how does the CBC look in a case of atypical pneumonia, and does mycoplasma IgM or chlamydia IgM help in diagnosis?
So unfortunately, you can't really distinguish clinically atypical versus bacterial pneumonia very well, unless the patient has some classical features like the patient has a rash or something, or the prodrome is really protracted, Sometimes you have a patient who doesn't look sick and you do the X-ray and you see a large patch, what you call as a walking pneumonia. And there is really no way by which your CBC also helps you, because you can get leukocytosis in atypical pneumonia. You can get other manifestations. Your CRP can be high. So it is very difficult to distinguish atypical pneumonia from, the normal bacterial causes. So I would approach it like this between an outpatient and an inpatient. In an outpatient, I would always treat with amoxicillin first or amoxiclav. And then if the patient is not improving, then think of a macrolide. But if your patient comes to you as an inpatient with very severe pneumonia, like requiring oxygen, and the patient is like above the age of 5 years or 10 years, then maybe there is a role of starting a cover for atypicals along with your beta-lactam. Now, these tests like chlamydia and mycoplasma IgM unfortunately really don't help you in the diagnosis, because one, your mycoplasma IgM can remain positive for a long time after a previous infection. So that is why even if you do an upper respiratory biofire and you get mycoplasma, it may be a colonizer. So most of the times, I think it is a good idea to treat pneumonia as per the age of the patient, and then so that you can use your antibiotics rationally.
Sure. There is a clinical question. I'll just read it out. So, when a patient with URTI with no nasal blockade, wet cough with occasional creps in chest, without any, fast breathing or retraction. Now, this is a case where the child only has wet cough with occasional creps, and there is no respiratory distress. So, ma'am, what should be the diagnosis and how to manage the noisy chest?
No, is the child having fever also?
So it's not been mentioned in the question. So, ma'am, suppose it is with fever, then, ma'am, what?
So basically, sometimes you can have patients who are wheezy kids, they can have cough and they can have occasional crept. So what I typically do is give them a bronchodilator through the spacer and see. And if your signs reduce, then means it may just be a wheezy cough, and a bronchodilator is all that is needed. But let us say you have a patient who has fever and who has cough and who has creps, even though there is no fast breathing, that's still, you would qualify it as a lower respiratory tract infection and you would give antibiotics. Because remember that definition of pneumonia, which is based on just the respiratory cutoff, is for the community health workers to recognize pneumonia. Now, as doctors, when we have access to the stethoscope, and if you are finding crepitations, then either those creps are because of some obstruction, like airway obstruction, like a wheezy child, or it may be due to a lower respiratory infection. So you can still, it's justified if you want to give antibiotics in such a patient.
And I have with respiratory infections only.
One more point I wanted to make is
yes,
that many times we mistake conducted sounds for creps. You have to be careful about that. And something what I normally do is that I ask the child, you put your stethoscope in front of the mouth and see, and then you ask the child to breathe through the mouth and not the nose, and you find that the conducted sounds disappear. So that also you have to be careful, before you're labeling ki child has creps. You are sure that you're not confusing a conducted sound or something else.
Yeah, so I think, ma'am, that's a very nice technique which you have told us. And ma'am, similarly, ma'am, we have spoken a lot about amoxicillin, amoxiclav, and cephalosporins. Ma'am, what about ferropenem? Are you using it?
Oh my God, we are really going into a dangerous area. So ferropenem, please understand, is not a oral carbapenem, okay? And this drug has actually not been licensed in Europe, in USA. It's only licensed in Japan and India. And there is not enough data surrounding its use. So first of all, you should not be using ferropenem in respiratory tract infections because you have so many other drugs which you can use. So the only attraction of ferropenem is that in ESBL urinary tract infection, suppose you have a patient with a UTI and you find that the urine culture shows resistance to cephalosporins, cotrimoxazole. But some of these patients will respond to cefixime. You find that the culture is resistant, but they respond. We are talking about those patients who have a ESBL UTI who are not responding to cephalosporins, where you don't want to admit and give IV antibiotics, you could try Pharopenem there. But again, I must tell you is that there is no susceptibility test available. See, we would feel confident about giving an antibiotic when we have a test like the urine culture report testing the sensitivity to Pharopenem. That is not there. So that is the biggest drawback of that drug. So please remember that can restrict the use of Pharopenem only to confirmed ESBL UTIs when you don't have any other option. Please don't go around using Pharopenem for respiratory tract infections, because we have so many antibiotics we can give. And in fact, there are some studies which show that if you use Pharopenem, you actually promote cephalosporin resistance. Carbapenem resistance. So if this patient comes to you later and you find that he's even resistant to carbapenem, you are in deep trouble.
And what about linezolid? We can use it orally
Linezolid, again, as I said, there are very few instances we should give linezolid for. I mean, I don't think in an outpatient we are justified. Like, for example, a patient comes with pyoderma, you normally give cephalexin as the first choice. Now, let us suppose the child does not improve and you send a pus culture and you find that it is grown MRSA. Now, you have to use a drug, but then again, see whether you can use cotrimoxazole, because many isolates are sensitive. See whether you can use clindamycin. Of course, there's a problem with clindamycin because the pediatric formulation is not available. So only if you have a MRSA, skin and soft tissue infection, which is cotrimoxazole resistant, and you have to use an oral drug, then you use linezolid. Otherwise, not. Now, the second situation is you have a child hospitalized. Okay, now here, you know, for example, let's say a pneumonia, most common state. Now you are, so all pneumonias don't need an MRSA cover, but let us say you have a child who has come with you with a pneumonia, which is necrotizing, rapidly progressive, with empyema, with whatever features, and you want to give an anti-MRSA cover. That is the time where you can choose giving linezolid. But remember that, you know, if TB is coming as a community-acquired pneumonia and you use linezolid, there may be problems. So that is again an issue. But I would restrict the use of linezolid very, you know, selective, like outpatient only for proven MRSA, and inpatients maybe, or you have a child who's coming with a severe skin and soft tissue infection, or maybe osteomyelitis, etc. Again, in osteomyelitis, if your patient is not very sick, there's no hurry to give an anti-MRSA cover. You can start the patient on cloxacillin or cefazolin and send your cultures. And then if your patient is not getting better, then add a anti-MRSA cover. Because one thing you have to remember, that if you start an anti-MRSA cover upfront and you don't have a culture to guide you, then if the patient gets better, then you are committed to using that drug for the entire duration of therapy, because you don't know how your patient got better. On the other hand, if you have a patient who has a pustule or a large abscess and who's sick, you send a pus specimen and you start the anti-MRSA cover, because you know 48 hours later you will have an isolate and you can actually narrow down your therapy. So those are the things which you have to keep in mind. Of course, if a sick patient with pneumonia goes into the ICU, you wouldn't hesitate. You would give an anti-MRSA cover also. So it all depends, you know, on what is the degree of sickness of the patient and what is the likelihood of the patient having MRSA when you take a call on adding an anti-MRSA drug. And in my practice in inpatients, I often use teicoplanin instead of vancomycin, because it can be given once a day, and you know, it's not associated with nephrotoxicity and this. And then later, if you've proven MRSA and you want to give an oral drug, then I give linezolid.
So ma'am, till now we were discussing about a child where the host is normal. So ma'am, now suppose this child has cystic fibrosis, already has an underlying chronic lung disease. And ma'am, in such cases, there's a question, how long can we continue long-term prophylaxis with azithromycin in a case of CF?
Okay, so I think Dr. Indu should have been on this. But yeah, so in cystic fibrosis, very few cases you will see. But in these patients, your etiology of respiratory tract infection is different. You have pseudomonas, you have non-tuberculous mycobacteria, you have Staph aureus. So the treatment in such patients will also include an anti-pseudomonal cover, especially if you have a previous isolate. And macrolides can be given for a long time in these patients, because macrolides have an anti-inflammatory effect as well. So, I mean, I'm not very sure, but people have used them for years, macrolides in such cases, or in non-CF bronchiectasis.
Sure. Ma'am, now, ma'am, let's move to GI infections, madam. So, ma'am, many times children come to us with tummy pain and a sonography is ordered, and then some non-specific mesenteric lymphadenopathy is picked up. So, ma'am, in such cases, like how should one go about? Should we treat, not treat?
So most common cause of tummy pain, which I see in my practice, is constipation. Okay, and any child you do an ultrasound on, you will get mesenteric nodes. I've never seen a child till now where you've done an ultrasound and mesenteric nodes were not found, because it's normal. All children get enteric infection, so your mesenteric lymph nodes will enlarge. So I generally, when I see a child with chronic abdominal pain, the first thing I do is to give them laxatives and see how they respond. And most of them, I think 90% of them settle with that. If they don't settle, then we go around treating them or investigating them. And I don't think there is any role of giving them, metronidazole or cefixime for 5 to 7 days because of the mesenteric adenitis, if it's a chronic presentation. Of course, sometimes you see patients who come to you with acute abdominal pain, and you find some right iliac fossa tenderness, then you think of appendicitis and you do a ultrasound, you don't see any appendicitis, but you see mesenteric nodes which are enlarged now, and that is a condition which is called as mesenteric lymphadenitis, acute mesenteric lymphadenitis, where there may be still some role of giving an antibiotic, but definitely not for chronic recurrent abdominal pain. Most of the times laxatives are good enough in these patients.
And ma'am, like for that condition, that acute mesenteric lymphadenitis, which antibiotic, ma'am, would you give?
I mean, I would use cefixime.
Cefixime.
Patients, because you're mainly thinking of E. coli. So cefixime is a good drug to use here.
And ma'am, suppose a child is coming with non-specific colitis-like symptoms. So do you treat, would you treat such a child? Would you order any stool routine, stool cultures?
Non-specific colitis means acute diarrhea, small volume diarrhea with abdominal pain and tenesmus. Yeah, so this is a older child, and sometimes these patients may not have bloody diarrhea, but they could still be having shigellosis. So in this kind of case, above the age of 5 years, who comes with this typical history of pain with tenesmus, with small volume stools, I may use antibiotics in such patients, where you can use cefixime or azithromycin. But again, I would not give a metronidazole, because most studies show that EH is not a common cause. If my patient does not respond to antibacterials, then I would use metronidazole here.
So ma'am, there's a question, what is the indication of metronidazole in diarrhea?
I think the indications are well laid out, that if your patient has bloody diarrhea or colitis who does not respond to carefully chosen anti-Shigella drugs, then you could use metronidazole in such patients, because, to demonstrate the trophozoites in the wet stool and all is difficult. So suppose you had a child coming in with bloody diarrhea and you've used, let's say, azithromycin or cefixime, not you've used Cipro, because our Shigella will not respond to Cipro. You use these drugs and your patient is not better, then you could consider using metronidazole.
Ma'am, how common do you diagnose giardiasis and amoebiasis on clinical presentation?
Not really. So, as I said, amoebiasis is not very common, and I would just follow that algorithm. Giardiasis, mostly you would think in a chronic diarrhea-like situation where you would do a stool routine and you find. So remember that finding the cysts of Entamoeba histolytica is not an indication for metronidazole, because it may indicate the non-pathogenic Entamoeba dispar. But presence of cysts of Giardia in the stool is a definite indication for treatment for giardiasis.
And ma'am, any role of stool culture nowadays, stool biofires?
Stool cultures, I mean, you can do it, but in bloody diarrhea, if you want to demonstrate Shigella, but most of the time we would treat these patients empirically. Stool biofire, I would not use at all in clinical practice in my immunocompetent host, because the cost of the test is 10-15,000 and you get multiple pathogens there. So I would treat syndromically. So I would treat conservatively. If there's no blood, if there's blood, then I would use cefixime or azithromycin here. If I have an immunocompromised host, a patient in the transplant unit or something who comes with diarrhea, then I would do a stool biofire.
But not for a healthy host. And ma'am, like you were mentioning about anti-Shigella drugs, and ma'am, we are always worried about HUS. And we know that sometimes when we use anti-Shigella drug, the incidence of HUS may increase. So, ma'am, how to go about it?
So, remember that studies have shown that using antibiotics for Shigella reduces mortality. Okay. So, I would use, if my patient has bloody diarrhea, I would use antibiotics because the incidence of HUS is not very high. So, I would definitely use. And there's one more interesting thing which I would like to say. Studies have shown that if you have Shigella and you don't use the right antibiotic, you actually worsen Shigella. Because what happens is that your other bacteria which are present in the intestine are destroyed by that other non-useful antibiotic that you have given, and the Shigella proliferates. So remember, please don't go around using nalidixic acid or ciprofloxacin for your bloody diarrhea because your Shigella is resistant and you are actually going to do more harm to the patient than good. But if I'm suspecting Shigella, I would give antibiotics and not worry about the risk of HUS.
Ma'am, what about the role of cefpodoxime in bacterial diarrhea?
No role. Cefpodoxime is actually an antibiotic for respiratory tract infections. There is no role of cefpodoxime in diarrhea or in enteric fever.
Ma'am, as I know this is for antibiotics, but ma'am, what is your choice of probiotics in diarrhea patients?
I really don't use my mind so much. I use any preparation. I don't think I can give brand names here, but I mean, whichever, I think they're all the same. And I don't use probiotics for diarrhea. Diarrhea, you give either zinc or you give ORS. Those are, or you give ondansetron, you give antispasmodic. Probiotics you should use only if it is antibiotic associated diarrhea.
And ma'am, as we are discussing GI infections, ma'am, how often do you see H. pylori gastritis, and do you ever suspect?
I mean, I know I don't see much. I'm sorry. Maybe I don't think of it often. Most of these patients go to the gastroenterologist because they have chronic abdominal pain who do an upper GI endoscopy. Of course, we now know that there's a stool test also available for diagnosis of H. pylori, antigen test in stool. So if you're suspecting in a chronic abdominal pain, you could go for that test. But again, I don't really think about it often.
Sure. And ma'am, our age-old typhoid fever, ma'am, enteric fever. So at present, ma'am, how should one approach enteric fever?
So first thing is that, you should, first of all, day 5, your patient is not getting better, looking toxic. You think of enteric fever, you send off your blood cultures. You do your CBC CRP, that gives you a clue, at least it rules out malaria, dengue and everything. I often also do an ultrasound because that helps me. Because, you pick up terminal ileal thickening, mesenteric nodes, splenomegaly, that also gives you indirect indication. Then you have to decide whether you treat your patient as an outpatient or inpatient. If my patient gets admitted, I give ceftriaxone. I don't start with combination therapy. Okay. If my patient is an outpatient, then I choose either cefixime or azithromycin. I generally tend to use cefixime more in these treatment because somehow I feel that azithromycin is a reserve drug because we have now emergence of ceftriaxone resistance. So that is why for stewardship I use cefixime, but you can use azithromycin also because the advantage is that it's once a day therapy and it's a shorter duration of therapy for 7 to 10 days, unlike cefixime which you have to use for 2 weeks.
And ma'am, the dose of cefixime?
20 mg per kg, max of 1200 milligram.
So, ma'am, you prefer monotherapy?
Yes, to begin with monotherapy. Now, there are some patients who are proven enteric fever who continue to have fever on day 7 despite therapy, and they are the ones where you would call as a clinical failure. Then you would switch the drug. So, of course, there's no data whether you should switch or add on a second drug, but that would be the situation where I would add on maybe azithromycin to the regime.
And dose, madam?
Dose is 20 mg per kg per day to a maximum of 1 gram.
Okay. And what is the sensitivity and specificity of typhoid?
0. Please don't do the test. It's not a good test. You will have so many patients with dengue who will be typhoid IgM positive. And you will have patients with culture-proven enteric fever who will be typhoid negative. So when you have to take a decision about treating for typhoid, look at the clinical setting, look at your CBC, look at your CRP, and then take a decision. Don't do it on the basis of the typhoid.
And ma'am, Vidal?
Again, it's no value in the short duration, but sometimes you see these patients who are having fever for 2 weeks. They have not got their blood cultures done. They have got this antibiotic, that antibiotic, not in a proper dose. And when they come to you, that is a situation where I often use the Vidal, because then if my Vidal is 1 in 320 both and there's no alternative diagnosis, I know it was probably typhoid. So that would be a situation where I would use the Vidal test in patients presenting with a PUO, but not in those patients who are coming with fever for 5 to 7 days. There is no role of doing a Vidal test.
So you're doing it in the 3rd week, madam. Vidal.
Yeah, sometimes, because the opportunity to diagnose typhoid has been lost. Because now if you send blood cultures in the 2nd or 3rd week, the sensitivity is very poor. So there you can use it as one test. And there also you are not looking at titers of 1 in 80, 1 in 160, but you do see these patients. I mean, we had a couple of patients like this recently who were running these fevers for 10 to 12 days come, and the only thing we got was a Vidal 1 in 320, and they responded to ceftriaxone. So we know that, you don't need to search for the cause of PUO more. You can just stop your search at that time.
And what is the role of amikacin in enteric fever?
No role, because Salmonella shows though it may show in vitro susceptibility, in vivo it is resistant. So there's no role of amikacin.
Okay, ma'am.
No role of amikacin in Shigella, in bacterial diarrhea also.
So ma'am, when do you prefer using amikacin?
Only in my ESBL UTIs. You have a urinary tract infection due to a cephalosporin resistant pathogen. You have admitted the child. Now you want to discharge. You have no oral options. You can give once a day amikacin.
For UTIs now, let's discuss about UTIs, madam. So which is your preferred drug to start for, like empirically to start for UTI, madam, till we get our cultures?
I use cefixime or amoxiclav, either of the two, in a OPD patient.
And if we have to pick one, ma'am, then which one would you prefer? Cefixime or amoxiclav?
See, I don't know, like sometimes, you have these patients who come to you with fever and they are like looking sick and their white cell count is high. And you are not really sure where the focus is. Okay, you've not got a urine routine back or whatever, or the urine routine, then I choose amoxiclav because it's a broad spectrum antibiotic and it would cover all the possible, like it would cover a pneumococcal illness, a early pneumonia, sinusitis, whatever. Because you know that cefixime doesn't work for those areas. So there I would use amoxiclav. But if I have a patient who has clear, a UTI, you have pus cells in the urine, 50, 60 and everything, then I would choose cefixime, because with amoxiclav, you get diarrhea and all those other issues as well. So that is why I would choose cefixime in that situation.
And ma'am, for recurrent UTIs, madam, which is your preferred choice for prophylaxis?
I generally use trimethoprim sulfamethoxazole because you have a syrup form available and you can give it. Nitrofurantoin, the problem is that syrup form is not available and can cause nausea, vomiting. So in children, definitely cotrimoxazole is the drug of choice. In small babies, let's say below the age of 6 months or something, then you can use cephalexin.
I'm just reading the questions. So they're asking if there's any role of cefixime in URTI or LRTI.
No role. Because see, cefixime is a 3rd generation cephalosporin. It doesn't cover pneumococcus, which is your #1 pathogen in pneumonias or bacterial URTIs. So no role of cefixime there.
And ma'am, for community-acquired pneumonias, any role of ceftriaxone there? Like we always see when the patient is admitted, the patient is started on.
Yes. That is definitely the drug of. So you use either coamoxiclav IV or you use ceftriaxone in these patients. So I think ceftriaxone is one of the most important antibiotics for pediatric ward patients, because you can treat your typhoid fever, you can treat your pneumonias, you can treat your meningitis, you can treat your UTI. So I think that's the antibiotic I most commonly use in my practice, in my admitted patients.
Ma'am, we have started the child on ceftriaxone, and then there is secondary worsening sometimes. So, ma'am, in those situations, how do you tackle it? It's
Which
quite
infection are we talking about?
Ma'am, in pneumonia only. Now, this community acquired pneumonia, the child was started on ceftriaxone, and the child is now worsening on that. So, ma'am, what would be the second line?
So again, you have to determine what is the cause of worsening in this patient. So is it a complication like a effusion or an empyema which has developed? Because then in that case, changing the antibiotic won't help. You have to do drainage. Second thing is that, are you dealing with some other pathogen which you have not covered? Like for example, could it be mycoplasma? Could it be MRSA? So, or is it a viral pneumonia that you're dealing with? Because they will not respond to ceftriaxone. So you will have to do that. But let us say you have a patient who is rapidly going down. You have admitted a child, is ceftriaxone you've started, and then it looks like a bacterial infection because there's a lobar consolidation or whatever, and the child's oxygen requirement is increasing. These are the kind of patients where I would probably add vancomycin and azithromycin, because by giving these three drugs, I'm covering the most common pathogens of childhood pneumonia. I would not go to piptazo, or I would not give meropenem, but I would give this because sometimes your child deteriorates quickly, and at the same time, I would try and do viral diagnostics because maybe you're dealing with an RSV pneumonia or an adenoviral pneumonia. So in that case, no matter how many antibiotics you give, patient will not be better. So I would probably do a nasopharyngeal swab for PCR in that situation. So if I know the diagnosis, then I can back off my antibiotics.
Sure. And ma'am, cefotaxime and ceftriaxone covers the same spectrum. So when would you prefer cefotaxime over ceftriaxone? This is a general question.
So only the newborn, because you can't use ceftriaxone because of its displacement of bilirubin and risk of kernicterus. But otherwise, we tend to use ceftriaxone because it's easy to give. You have to give cefotaxime 6 to 8 hourly, which is cumbersome. So another situation where you would probably use cefotaxime is, suppose your patient has liver impairment, or your patient already has sludge in the gallbladder or something, that ceftriaxone can cause it. So maybe then you could use cefotaxime. But otherwise, I think ceftriaxone is pretty okay.
There are many questions on ceftriaxone itself. Ma'am, is there a risk of developing resistance to ceftriaxone because of its common use or misuse?
Yes, it is developing. So your ESBLs which have come in, which are causing urinary tract infection, is the reason. But you must understand that even with all this resistance around us, 80% of your infections, community-acquired infections, can be successfully treated with ceftriaxone. Of course, you have to use other drugs. For example, if you have meningitis, ceftriaxone is your main drug, but you add vancomycin because pneumococcus has shown resistance. If you have pneumonia, your ceftriaxone works well, because remember that even if your pneumococcus has developed resistance, it will, ceftriaxone in a dose of 100 mg per kg will work for your intermediate resistant pneumococcus in the non-meningeal system. If you have typhoid fever, you have isolated reports of ceftriaxone resistance, so it will work. Even if you have a urinary tract infection with ESBL pathogens, you often find that ceftriaxone works in these patients because the drug is, just because of difference between in vitro and in vivo susceptibility. So although there is resistance, but I mean, I'm sure other people will agree that in most of your cases, you can successfully treat with ceftriaxone. And it's such a cheap drug, and it is so convenient to give.
And ma'am, now there's a question like a patient was treated with IV ceftriaxone for pneumonia during the inpatient stay, and now we're discharging the patient. So which antibiotic would you give for outpatient?
So, I mean, you can give either cefuroxime or you can give amoxiclav. You can use any of these two drugs because, because if you use ceftriaxone, which covers pneumococcus, Hib, Moraxella well. Now, if you had a patient who's above the age of 5 years where Hib is not a concern and your pneumococcus is the concern, you can even discharge an oral amoxicillin. So switch of the class is not an issue. I generally don't switch to cefpodoxime. I would, even if I have to use a cephalosporin, I would probably prefer cefuroxime there. Or you just go to amoxiclav. So it's fine. You've given ceftriaxone as an inpatient, can switch to amoxiclav as an outpatient. Especially if you had a patient with sinusitis where you can't give amoxicillin alone. So I would switch to amoxiclav.
Okay, ma'am. Ma'am, there's a question on conservative management of suspected appendicitis.
Yeah, so that's a very good question. You have these patients who come with you appendicitis, and now there's a role of conservative management. So it depends on whether you're treating them in an outpatient or inpatient. But if the patient is inpatient, then ceftriaxone and metronidazole is something which you can give for these patients because your main pathogens are E. coli and anaerobes. And if the patient is not very sick, then I usually give them cefixime and metronidazole as outpatients for treatment of conservative management of appendicitis.
And what would be the duration?
5 days.
Okay, ma'am. Ma'am, if we are suspecting meningitis, say in a 6-month-old baby, then and patient is not willing for admission and injectables, then what to do in such a situation? This is a question, ma'am.
So you would wash your hands of that patient. You would not prescribe oral antibiotics to that patient. Definitely. I know, I mean, you would do more harm than that. You should just put your foot down and say, because I mean, you are also medico-legally liable here. You are writing in your paper that I'm suspecting meningitis, and then because you could just say that advise admission, parents not willing, DAMA or whatever you do. You would not give oral antibiotics to this patient. Similarly, you wouldn't give oral antibiotics for newborn sepsis.
I'm just searching for more questions.
Because sometimes, parents want somebody to tell them, no, you can do oral. So once they want an easy way out, if you put your foot down and say, I will not write oral antibiotics, let them go to somebody else. But, it's okay. Or maybe then they would really realize the gravity of the situation and, admit the child.
Sure. And ma'am, for suspected peritonitis, what would be the best antibiotic?
So again, it depends on whether you think you're primary or secondary peritonitis. So you have a nephrotic syndrome or you have a chronic liver disease with ascites. You would think of, and here your pathogens are mainly pneumococcus, E. coli and all. You could use ceftriaxone. On the other hand, if you have a patient with perforated appendix and peritonitis, then your choice would be different because you want to cover anaerobes. You would use either ceftriaxone with metronidazole, or you would use piptazo or cefoperazone sulbactam in such situations if the patient is really sick.
And ma'am, we'll now quickly go through different sites for infections, ma'am. So suppose if there's acute dactylocystitis, what would be the antibiotic of choice?
The cryocystitis, many times it happens because of adenoid enlargement and the pathogens are the same, your pneumococcus. So coamoxiclav is a good drug to give in these patients.
Preseptal cellulitis, madam?
Coamoxiclav or IV ceftriaxone.
Orbital cellulitis?
Orbital cellulitis, you have to admit these patients because they can get other complications. So ceftriaxone is the drug of choice because your pathogens are mainly pneumococcus, Hib, Moraxella, Staph aureus.
Periungual suppurative infection, madam? Antibiotic of choice?
So cephalexin, because it's mostly Staph aureus.
And ma'am, duration?
Again, 5 to 7 days. I think nowadays most of the people are, except for certain exceptions where you give 10 to 14 days of therapy, 5 to 7 days treatment is enough for most situations. Even in fact, now there are studies which have shown that for urinary tract infection, also 7 days of treatment is enough. And you don't need to give like what we used to give 10 to 14 days.
And ma'am, mastoiditis?
Mastoiditis, you have to give 2 weeks. Again, the same drugs which you use for otitis media. That is why if you have a patient who comes to you with otitis media is toxic, you always should check for the tenderness on the mastoid. And if they have mastoid tenderness, you would give 2 weeks of treatment.
And ma'am, if the child has impetigo?
Again, impetigo, if it is localized, you can use topical antibiotics like fusidic acid or mupirocin. But if it is extensive, multiple sites, recurrent, then again ceflexin.
Okay. Ma'am, now we'll go to neonatology. One question has come up. A role of beta D glucan for neonatal fungal infection. Is there any role?
Nothing. No role, because it has not been standardized yet. Neonates have high BDG levels. Blood transfusions increase BDG, so it should not be used as of now.
So, ma'am, which test can be used?
Blood cultures. And if you, so that is the test which you would use. Urine examination for Candida. Those would be the tests where you would do, which you would do for diagnosis of neonatal candidemia.
And ma'am, when to consider metronidazole in GI cases?
I think we've already answered that you have a colitis or you have bloody diarrhea and your patient is not improving with anti-Shigella drugs, then you could use metronidazole. Again, there is no role of giving drugs like O2 on Oflox or nidazole because your Shigella won't get covered by ofloxacin. So you have to use separate drugs because you have to give dosages separate. So no role of giving Ciplox, TZ or O2, etc. in these patients.
And ma'am, if we get a patient of septic arthritis, so how do we treat inpatient, outpatient?
Again, septic arthritis, you have to admit the child and you have to do drainage of the joint because that is important in these patients. You have to send your cultures, blood culture and this, and most of it is due to Staph aureus, maybe Kingella or something. So you would start either cefazolin or cloxacillin in these patients as the empiric antibiotic.
Ma'am, it's 10:30 now, so we'll be wrapping up, but if you don't mind, we'll take one or two questions.
Okay, sure.
So, ma'am, what is the management of traveler's diarrhea?
So traveler's diarrhea is typically for people from abroad who come where your pathogens are E. coli and all. So again, as I said, if you don't have bloody diarrhea, you again would, in our country, you would give symptomatic therapy with ORS and zinc in children below 5 years. But so this is different. In adults, the treatment would be different where they would use probably an antibiotic. But in children, you don't generally use antibiotics unless there is blood in the stool.
And ma'am, is there any role of oral antibiotics in neonates?
I don't, for neonatal sepsis, definitely not. But like you have a neonate who just has a skin and soft tissue infection, some furuncles here and there, then you can use cephalexin, but generally not otherwise. Even if you have a UTI in newborns, you would start treatment with IV because remember that this is a very compromised population and one error on your part may cause sepsis, which has a mortality of 20% or meningitis. So you have to be careful in newborns.
Ma'am, there's a question on MDR, Klebsiella, and neonatal sepsis. Ma'am, can you highlight antibiotic use like Astronam and I think this is some error. Yeah,
so if you have, that's an XDR Klebsiella because MDR may still be susceptible to carbapenems. But if you have a carbapenem resistant Klebsiella in newborns, as per current guidelines, the treatment of choice is ceftazidime avibactam with or without Astronam. So you do a susceptibility to Cas-Avi. If it is susceptible, you use it as monotherapy. If it is resistant, then you use a combination. And that regime is better than a polymyxin or colistin or phosphomycin-based regime. If you have E. coli, which is carbapenem resistant in newborns, you can use phosphomycin. And only if you have Pseudomonas or Acinetobacter in newborns which are resistant to carbapenems, then you use drugs like colistin-based therapy because there you don't have other options.
I think, ma'am, we have taken most of the questions. And
Sure.
I think one last question, refractory worm infestation, madam, management.
So in refractory worm infestation, I assume they're referring to pinworms because those are the kind of, infections here. The problem is auto-infection. So some of the things which you have to do is treat all the family members and you have to make sure that the child, most of these children, what they're doing is they're scratching their bum and then they're putting their hands in the mouth. So to keep the nails clipped short, you have to make sure that the bed sheets are changed because otherwise the eggs lie on the bed sheets. So those are the other things you have to do in these patients for pinworms, which you have to do. and you have to repeat the dose of albendazole after 2 weeks.
Any role of giving albendazole for like 6 months, like every 14 days or
No,
every
so there
month
is no
for
rule.
6 months?
No, it's a good question. There is no rule because so many patients ask me, ki 6 months ho gaye, shall I give albendazole? Even in slums where the burden of worms are very high, there was no benefit seen with periodic deworming. So we are talking about children belonging to a reasonable socioeconomics class where the worm burden, even if it is there, is likely to be low. And there are so many things which people think is due to worms, like clenching the teeth or bruxism or white spots or the child wanting too much sweet is again a sign that the child has a worm infestation. So again, this is highly misused, anti-helminths.
Sure. Thank you so much, madam. I think that like you have covered most of the questions, and all the answers were so crisp, madam, and we could understand when you said that we have to educate the patient so that the use of antibiotics is decreased, even on the behalf of the parents themselves. As you mentioned, they are sometimes using azithromycin themselves and then coming to us. So with that, thank you so much, madam. I would give it to Chokhani sir now. Thank you, ma'am.
Nehal, you can wind up.
Madam, we would like a super over. I
Nehal?
think this. Hello,
Yes.
am I audible, sir? I thought, okay, it was muted. So with madam's session, super overs can go on maybe. But of course, looking at the time, thank you so much, madam. It's always a pleasure listening and getting answers from you, because then it's done. It is very crisp and clear. And of course, thank you, Reepa, for moderating this entire thing so wonderfully.
Very
So
nice.
thank you all the participants who have been with us consistent for all the 4 episodes of our Webflix. And of course, as sir has rightly mentioned in the chat, that there are many names where we know that they have voted. But since it's the last, maybe just about 20 hours, 24 hours, not even 24 hours, less than 20 hours now. So people who haven't voted, please log in. It's going to take only 2 minutes, not more than that. And please vote for the elections. Thank you so much. Have a lovely evening and weekend. Thank you all once again.
Thank you, everyone. Thank you.
Thank you, madam.
Thank you.